learning objectives for this webinar are as follows. By the end of the webinar, participants should be able to discuss the incidence and major causes of miscarriage, stillbirth, and neonatal death, describe the major genetic contributors to miscarriage, stillbirth, and neonatal death, and explain the benefits and limitations of genetic testing in cases of miscarriage, stillbirth, and neonatal death. Over the next 40 minutes or so, Dr. McPherson and I will cover the following: an introduction to our topic. Dr. McPherson will talk about the incidence and causes of miscarriage, stillbirth, and neonatal death. We'll then talk about the chromosomal and Mendelian causes of these disorders, introduce you to Prevention Genetics Solution, and then there will be time for questions and answers at the end. And with that, I'm going to turn it over to Dr. McPherson.
When a woman gets a positive pregnancy test result, she usually anticipates that she's going to have a healthy baby. But unfortunately, that only happens 85% of the time. And today we have to talk about the other 15%, the things that can go wrong between that recognition of pregnancy and the taking home a healthy infant. First, because it's the most common, we'll talk about first trimester miscarriage. This is very common. It happens in 1 out of 8 to 10 recognized pregnancies, and 1 in 100 couples will experience it 2 or more times. It's devastating for the mother, though. There's no baby to see and mourn, so she's not quite sure if she is a mother or not. She tends to feel shame and self-doubt and sometimes be blamed by others. The traditional evaluation is expensive, invasive, and because it's focused on maternal illness, it can actually contribute to this problem of shame and blame of the mother. In case you wonder, this picture on the left is about an 8-week embryo that turned out to be triploid and had abdominal wall and cranial defects. The most common cause of embryonic death or miscarriage in the first trimester is chromosomal aneuploidy. This accounts for more than half of all the losses. And unlike diagnosing aneuploidy in an older child, you can't do it just by looking. Visible malformations are not always present in aneuploid fetuses. In fact, they're only found about 20% of the time, and they can be present also in fetuses that have normal chromosomes. The maternal evaluation, the traditional approach with parental karyotypes, antiphospholipids, evaluation of the uterine cavity, thyroid studies, and prolactin, if it's done on untested recurrent losses, will yield a result only about 14% of the time. If you separate by the chromosomal losses and the non-chromosomal losses, you can change those odds so that if you focus on the ones that are chromosomally normal, you get a useful answer 35% of the time, and you don't have to offer the test to those that are chromosomally abnormal. On the right here, I'm showing the types of chromosomal abnormalities that are found when a microarray is done on a first trimester loss. You'll note the majority are common trisomies, but Turner syndrome and structural abnormalities are also quite common, as is triploidy. So the take-home message for this part is that recurrent first trimester pregnancy loss, the best approach is microarray of the products of conception, not the parents. You'll get a result more than 90% of the time, which is much better than if you try to do karyotype just looking for aneuploidy. And if you get an abnormal result, you're able to stop there. You can avoid having to do the whole recurrent pregnancy loss evaluation. Instead, you can go straight to reassurance because the recurrence risk will usually be low. On the other hand, if you do get a normal result on the chromosomes for the products of conception, you can proceed with the recurrent pregnancy loss evaluation for the parents, and you'll have a greater chance of getting an answer. Moving on to the losses that happen in the second trimester, I'm making the argument here that these should be considered early stillbirths rather than miscarriages. They're not as common as first trimester miscarriages, although they are more common than later stillbirths. The recurrence risk is higher than for stillbirth. Losses between 13 and 20 weeks deserve full evaluation. This is partly because the families want it. They are naming, burying, and mourning these children. It's partly because the causes you'll find will be similar to stillbirth. About 25 to 30% will be fetal. And it's also because you need this information for counseling, because a woman who experiences a loss of this type has a recurrence risk for stillbirth as well as for second trimester loss. Stillbirth, it's always a shock. When the baby isn't moving and the heartbeat can't be found, a couple is moving from planning for a baby to planning for a funeral. And the people caring for them are also in shock, oftentimes to the point that they may not be quite ready to start the next stage, the effort of helping the family through their grief and gathering data to answer their future questions. Yet stillbirth isn't that rare. It happens 1 in 160 in the U.S. And the recurrence risk information is going to depend on the cause. But even though the recurrence risk is only 3%, that's 5 times the risk of stillbirth happening to someone who's never experienced it before. When they come out of their shock and grief, almost all families are going to want to know, why did our baby die? Is it our fault? Is it going to happen again? Can we prevent it? And the information has to be gathered at the time of the stillbirth in order to be able to answer these questions later. Causes of stillbirth obviously vary depending upon how you define these causes. One group that's been looking at it is the Stillbirth Collaborative Research Network, and they found a probable cause in at least one probable cause in about 60% of stillbirths, and a probable or possible cause in about 80%. Now, you'll see these causes add to over 100%, and that's because many of them have more than one cause. That's important because it means that even if you suspect a particular cause, you shouldn't stop looking for other contributing causes. Over on the right, I have the results of the over 3,000 cases that have been evaluated through the Wisconsin Stillbirth Service Program. Again, we're finding a probable cause in about 60%. And you'll note here that the probable cause is fetal 28% of the time. Neonatal death, again, it falls in the same spectrum with second trimester losses and stillbirth. The family is experiencing the same kind of thing and is going to have the same kind of questions. The frequency and range of birth defects that you find in neonatal deaths occurring usually in the first week, but sometimes up to the first month after birth, is actually quite similar to stillbirths. And in the U.S., about 1 in 4 per 1,000 babies dies neonatally, and about 1/5 of these are due to birth defects. The causes of neonatal death depend a great deal on how frequent neonatal death is in the population you're studying, because that's a measure of how the healthcare system is working. In Japan, where the frequency of neonatal deaths is the lowest in the world, almost half of them are due to birth defects. In other countries where they haven't been able so far to eliminate as many other causes like birth injuries and prematurity, a correspondingly lower percentage will be due to birth defects, and there'll also be more unknown causes. So now, if we look across the spectrum from second trimester losses through stillbirth and neonatal death, we see that the number of fetal causes is going to be highest in developed nations where other causes are less. And it's going to be highest for deaths that occur before birth or in the neonatal period compared to intrapartum, where obstetric complications are more important. Also here we begin to see the chromosomal contribution, which if you do only karyotype, as we did in the Wisconsin Stillbirth Service Program until recently, you see about 5 to 6%, but if you move to microarray, you start to see 8 to 10% of chromosomal causes. The recurrence risks are going to depend on the exact diagnosis, and they're going to average lower for fetal causes than for maternal or placental causes, which makes it particularly important to identify the fetal causes so that you can provide the right recurrence risk information and management for future pregnancies. Now, many times, both families and doctors will say, if the baby looks normal, do we really need to be checking for a genetic cause? But in fact, you do. Fetal abnormalities are very easily missed, especially if gestational age is young. Here we have a foot of a baby that was born at 26 weeks, born alive, but died after unsuccessful resuscitation. After the baby died, they noticed this webbing of the second and third toes, and eventually this baby was diagnosed with triploidy. Also, maceration, the changes that happen after the baby has died in stillbirths, may hide or may mimic birth defects. In the lower right here is the hand of a baby that was dead for probably several days before delivery. And there is some curving of the fifth finger, and there does appear to be a single crease across the palm. But you might have the question, is that curving real, or is it just an artifact that happened because of postmortem change? However, testing did show that this fetus had Down syndrome. Fetal causes account for about 1 in 4 stillbirths, and of those fetal causes, about half are amenable to genetic testing with chromosomes or testing for single gene disorders. The chromosomal causes are comparable, although more frequent, to what you see in live births with Down syndrome, trisomy 18, and trisomy 13, but also Turner syndrome is a major cause of stillbirth and late miscarriages. Triploidy is still here, you'll notice, as well as structural chromosome abnormalities, and they'll be important for a reason I'll get to in a moment. The other part of that half that's amenable to testing is Mendelian, known single gene disorders, and hydrops fetalis, which may be due to single gene disorders more often than we recognize. In neonatal deaths, they have used ICD-9 and ICD-10 coding for breaking down the causes, and therefore we aren't able to separate the chromosomal and Mendelian as well. But I do want to point out that there are 18% chromosomal causes in the neonatal deaths in Japan, and there also are 15% hydrops, again, from the study in Japan. Chromosomal causes usually are going to be reassurance for your patient. If it's one of the common trisomies, the average recurrence risk is going to be 1% or 1.8 times the maternal age risk. But that includes live births with trisomy. So the recurrence risk for stillbirth is actually going to be much, much less, but you are going to want to offer this patient testing or screening for problems that could occur in a live birth. With Turner syndrome and with triploidy, the recurrence risks are quite low, and you can provide reassurance. The only group where further testing is likely to be necessary in the parents is if you find a structural abnormality in the miscarriage or stillborn or natally deceased infant. There, parental testing may be needed. If a parent is a carrier, recurrence risks might be significant, and additional counseling might be needed. Also, if you find something that caused the death of the baby, it's possible that the same thing could be present in other family members and could have important implications for their ongoing health. Now, moving on to Mendelian disorders. Although most of these are individually rare, collectively they account for at least 10% of fetal causes of second trimester loss and stillbirth, and possibly quite a bit more because these data are from the Wisconsin Stillbirth Service Program group, which did didn't, until recently, have single gene testing for most of the babies that were evaluated. Visible abnormalities, such as skeletal dysplasias, may be obvious and may prompt specific genetic testing. But unfortunately, a lot of other abnormalities are more difficult to recognize in stillbirth. They may be subtle in a small or macerated child and much harder to recognize than in the live birth or older child or adult. Also, in order to diagnose a single gene condition, you usually have to suspect it in order to order the right test. A panel for common, easily missed Mendelian causes of stillbirth can offer the opportunity to detect conditions that haven't been suspected based on clinical examination and yet are important for the family moving onwards. One example is lethal multiple pterygium syndrome or fetal akinesia. This turns out to be the most common Mendelian condition that's found in the WISP cohort. And most of those cases were not recognized at delivery, but were recognized later through the medical geneticist reviewing the autopsy and photographs and other clinical information. On the right, there's a picture of an infant which was actually the third loss for this particular family. And all of the losses had the swelling on the back of the neck, the cystic hygroma, but only on the third loss was this webbing of the elbow noticed, which provided a clue. There are multiple genes that contribute to lethal multiple pterygium syndromes and akinesia. They're mostly recessive, so the recurrence risk for the family is going to be 25%. Test results on the affected baby are needed to offer future prenatal diagnosis. There is a next-generation sequencing panel available already, but you have to suspect this condition in order to order it. But it is included in the miscarriage, stillbirth, and neonatal death panel in order to catch unrecognized, unsuspected cases. A different issue arises with a Mendelian condition like Noonan syndrome, which is extremely variable, so that it can be missed until it presents very severely. In this particular family, whose pedigree is shown on the right, a baby boy was stillborn. There was no autopsy, so they don't know if he had congenital heart disease. Subsequently, his sister died neonatally and did have congenital heart disease. Both infants had mild hydrops and cystic hygromas. After evaluation of the little girl, the father was evaluated in medical genetics, noted to have mild facial features and short stature. So all of these were consistent with Noonan syndrome in the family, which was subsequently confirmed through genetic testing. Noonan syndrome can be due to multiple different genes, which are autosomal dominant. It's variable within a family, so if it's found in the baby, it's going to be necessary to test the parents. The recurrence risk could be 50% if the parent has it, and minimal, only about 1% if the parent doesn't. Again, there is already next-generation sequencing available, but we're including it in the miscarriage, stillbirth, and neonatal death panel because we believe there are many cases where it's not suspected and therefore the testing isn't getting ordered. A third example, Smith-Lemli-Opitz syndrome, seems to be more rare than the other conditions I mentioned. But we have a genetic puzzle with it, because the prevalence in living individuals is only about 1 in 30,000. When you test for carriers, you find up to 1 in 30, which would lead an expected prevalence of 1 in 3,600. So where are the missing babies? Thinking that they are miscarried or that they might be stillbirth or neonatal deaths that were never fully diagnosed. There is, so far, one gene that's responsible for virtually every case of Smith-Lemli-Opitz syndrome. It causes a problem with cholesterol biosynthesis. It's recessive, so the recurrence risk is 25%. And treatment is available and more effective if started early. On the right, there's a baby that died neonatally because of Smith-Lemli-Opitz syndrome, and he has many minor birth defects, some of which you can see in this photograph, like polydactyly. But others who don't have polydactyly could be much more easily missed. there are a lot of babies that look normal, but still are born still or die neonatally, and we never find a reason. If a gene can cause sudden death in older children and adults, it's reasonable to worry whether it can also cause sudden death in fetuses or newborns. And in fact, there are now a number of families who have been documented to have conditions that cause sudden death, like long QT syndrome, which also contains stillbirths, miscarriages, and neonatal deaths that have been attributed to sudden infant death syndrome. This is one such family where there have been sudden deaths at all ages, ranging from prenatally to adult, and where living individuals had long QT syndrome and could be appropriately treated and prevent them from also suffering sudden death. At the Mayo Clinic, a group studied just 2 of the sudden death genes in a group of unexplained stillbirths and second trimester miscarriages. And just studying those 2 genes, they found that 10% of unexplained stillbirths after 20 weeks were due to mutations in those genes, and 7% of unexplained second trimester miscarriages were due to mutations in the same genes. And again, this is information that's not only important for explaining the loss, but could be life-saving for family members. Now, I mentioned earlier hydrops as a cause of stillbirth and neonatal death. Hydrops is actually almost as frequent as all the Mendelian conditions combined, and it accounted for 7% of all neonatal deaths in Japan. Now, this is a number that includes even the ones that are due to prematurity and so on. Still, 7% are due to unexplained hydrops. There were 99 cases in the Wisconsin Stillbirth Service Program cohort, which was 3% of all the cases evaluated. Often overlooked or attributed to maceration, so that real numbers could actually be much higher. Idiopathic in hydrops just means we don't know yet. It was used to distinguish it from hydrops due to known hematologic diseases like Rh incompatibility or alpha thalassemia. Recurrence of second trimester losses or stillbirths with hydrops is 8%, which is higher than the overall recurrence risk. That means that we're missing some genetic causes, which could be metabolic diseases. They could be lethal multiple pterygium syndrome, which has hydrops with it. They could be Noonan syndrome. They could be Smith-Lemli-Opitz, which can also present with hydrops. So the bottom line here is that idiopathic hydrops is at least sometimes due to an underlying genetic condition that's being missed. And now I'll turn it over to Diane so that she can talk about the prevention genetic solutions.
Thank you, Dr. McPherson. That was a really excellent clinical overview and really describes all the different reasons why miscarriage, stillbirth, and neonatal death may happen. So given the information that Dr. McPherson was just sharing with us, we realized that there was an unmet need in genetic testing offerings and set out to provide a comprehensive solution to provide critical information in the cases of miscarriage, stillbirth, and neonatal death. Our solution is a stepwise approach in order to provide the most clinically relevant information for the least cost, and this is in keeping with our philosophy of utilization management. So all of the specimens received, and these could include cultured cells, fresh or frozen tissue, blood, or DNA, will first be tested using a chromosomal microarray to detect cytogenetic abnormalities such as triploidy, aneuploidy, and microdeletions and microduplications. And any specimen that has a positive result on the microarray will be reported as positive, of course, and then charged only for that portion of the test. Specimens that are negative by microarray will then be automatically reflexed to the 40-gene next generation sequencing panel from which the final report will be issued. It is also possible to order just the chromosome microarray or just the 40-gene panel if desired. Our Prevention Genetics CMA ISCA is a whole genome microarray with approximately 110 distinct comparative genomic hybridization, or CGH, probes distributed across the entire genome with a median probe spacing of approximately 25 kilobases. And there are also 59,000 single nucleotide polymorphism, or SNP, probes. The advantage of including SNP as well as CGH is the detection of triploidy, a common finding in pregnancy loss specimens, as Dr. McPherson pointed out, and triploidy cannot be detected using a traditional comparative genomic hybridization microarray alone. So in the array CGH, which is shown on the left side of this schematic, the patient DNA is labeled with one fluorescent dye, in this case green, and is mixed 1-to-1 with a reference DNA, which is labeled in this case with a red fluorescent dye. The DNA is hybridized to a slide containing the probes that span the region of interest, or the whole genome in this case. Typically, the probes are spaced closer together in coding regions and further apart in non-coding regions, just to maximize the detection of clinically relevant rearrangements. If there are equal amounts of patient and reference DNA binding to a particular probe, the fluorescence will cancel each other out, and you'll see a spot, blue in this case, to show that it's normal. If there's more of the patient DNA indicating a duplication, then you'll see a green fluorescence, whereas if there's more of the reference DNA indicating a deletion in the patient DNA, you'll see a red fluorescence. Of course, this is not done by eye. As shown in this schematic, it is measured by a scanner and then output to computer, where it can be represented graphically. For SNP testing, which is shown on the right side of this schematic, the labeled patient DNA is hybridized to oligonucleotide probes that contain either of the two possible sequences at a given SNP and are differentially labeled. If the patient is homozygous for allele A, the DNA hybridizes only to the oligonucleotide probe corresponding to allele A. Similarly, if the patient is homozygous for allele B, the DNA hybridizes only to that probe. But if the patient is heterozygous, the DNA hybridizes to both of these probes. So by examining the hybridization pattern across thousands of these SNPs, almost 60,000 on our array, one can then determine both the heterozygosity in the region and the number of copies. And so you can see at the bottom right what you might see, the fluorescence you might see with different combinations of a SNP. So we use both of these pieces of information together, the comparative genomic hybridization and the SNP hybridization, to determine if a chromosomal imbalance is present. So why is this important? Well, if we just remember, as Dr. McPherson has told us, chromosomal imbalances affect a significant proportion of pregnancy losses. For first trimester miscarriages, more than 50% are due to cytogenetic abnormalities. For stillbirths, approximately 10% overall, and as many as 30% of cases with a fetal cause are due to cytogenetic abnormalities. And 5% of all neonatal deaths and 20% of those with a fetal cause are due to cytogenetic abnormalities. In addition to this, the microarray can detect not only gross chromosomal abnormalities such as triploidy and aneuploidy, but can also detect submicroscopic changes. The failure rate of microarray compared to traditional karyotyping, specifically in the miscarriage and stillbirth types of specimens, is much lower, on the order of about 10% compared to 20 to 40%, depending on the samples that you're using. And finally, and this contributes to the improved success rate, there is no requirement for tissue culture. DNA can be extracted directly from fetal tissue, which means that even macerated samples are often successful. As I said before, if the microarray is negative, we will reflex to the 40-gene next-generation sequencing, or NGS, panel. NGS is a catch-all term used to describe a number of different approaches to high-throughput sequencing. The method we use here at Prevention Genetics is the Illumina platform, and the overall goal of any NGS is to sequence vast numbers of short reads in a short time frame and then align them to the reference sequence in order to detect variants in a number of different genes at the same time and at an improved cost. On the platform that we use, the DNA is sheared into short pieces, and adapters are attached to each end of every fragment. Using the adapters, the DNA is annealed to a slide, and PCR is carried out using a method called bridge amplification to create many copies of the same piece of DNA, which then become your templates for the sequencing reaction. The PCR fragments are denatured into single strands and sequenced using a method called sequencing by synthesis. What this means is essentially one base at a time is added, and the fluorescence from that base is read before the next base is added. So this creates thousands of 150 base pair sequencing reads that are then aligned to your reference sequence for all the genes of interest and analyzed using computer algorithms for specific variants. Any variants that are detected during the NGS process are confirmed by Sanger sequencing before reporting. Our NGS panel includes 40 genes that are associated with the conditions that Dr. McPherson mentioned previously. And these include 8 genes associated with fetal akinesia lethal multiple pterygium syndrome, 13 genes associated with Noonan syndrome, 15 genes associated with metabolic disorders that can cause high drops, 3 genes associated with sudden cardiac death, and the SLOS gene associated with Smith-Lemli-Opitz syndrome. These genes were carefully selected in consultation with Dr. McPherson to capture the major fetal causes of miscarriage, stillbirth, and early neonatal death beyond chromosome abnormalities. Although no studies have been done to determine the clinical sensitivity of this particular gene panel, we are confident that this panel will detect causative variants in a significant proportion of cases. One of the major advantages to our panel is that it is built on our exome backbone. That means that it is easy to reflex to exome for a reasonable additional cost if in those cases when both the microarray and the panel are negative, and if the further testing is desired and a genetic cause is strongly suspected. So hopefully over the past 40 minutes or so, we have convinced you that the genetic analysis of pregnancy loss is important, and we'd like to leave you with these take-home messages. So clearly, miscarriage, stillbirth, and neonatal death are devastating causes that sadly happen every day. Every obstetrician sees these cases in his or her practice on a regular basis. The fetal causes for these issues are common and frequently missed for many of the reasons that Dr. McPherson mentioned. There is a very brief time window, particularly in the case of miscarriage and stillbirth, to gather and save the information and material needed to find the cause. And finally, we hope that our Prevention Genetics Comprehensive Miscarriage, Stillbirth, and Neonatal Death Panel offers a simple, stepwise approach to find answers for your patients.
Just a reminder that if you'd like to submit any questions, please do that through the Q&A or the chat dialog box on the right-hand side of your screen. It looks like we have a number of questions coming in. The first one that I have for you is, can you speak to the specimens that have been validated for this test, and specifically, can we accept paraffin-embedded tissue?
At this point, we are not able to accept paraffin-embedded tissue. That's because the quality of DNA that's extracted from such tissue is very compromised and very fragmented. So in particular, microarray does not work well for this type of tissue. So we are validated for any type of fetal cell culture For tissue, that can be fresh or frozen. For blood, so cord blood, or if in the case of a neonate, the blood from the baby, and for extracted DNA.
This is Dr. McPherson. I'd like to add that from my experience, if there is maceration, placental tissue is frequently much more useful for obtaining DNA than tissue from the fetus, and also can be obtained without the need for an invasive autopsy. And we are validated for any DNA and any fresh or frozen tissue, including from the placenta.
Great. Can you speak a little bit as how you selected or maybe limited the genes on the panel, and then address whether or not whole exome sequencing could be a reflex option?
When I was thinking about this panel, I wanted to select genes for conditions that were relatively common in my experience of over 3,000 stillbirths, and that were easily missed. So even though there are a few common conditions that aren't included, it's mostly because they're less easily missed. For example, some of the skeletal dysplasias. We also, once we decided to include a group, we'd keep the group together. So even though in Noonan syndrome, one gene does account for more cases than any other, since we were looking for Noonan syndrome, we thought it was appropriate to look at all of the genes that we have in our other tests for Noonan syndrome.
And just to speak to the reflex exome, that is something that is relatively simple to do. There would be an additional cost associated with it, but because the panel is built on our exome backbone, it is an easy reflex to accomplish.
So maybe a related question that came through is, has prevention looked at doing whole exome sequencing with recurrent loss? And this specific provider asked other labs and they declined given the lack of phenotypic data. So what are our thoughts on that?
I think there are probably a number of reasons why whole exome is not the first test of choice. The first one is that a lot of these cases are caused by chromosomal imbalances. So microarray is clearly the first test of choice in these cases. And then we may have limited material, so trying to choose those genes that are likely to give us the most information is important. But again, as I said, we have built this on our exome backbone so that we can reflex, provided there's sufficient material to do that.
Can you speak to our depth of coverage for the next-gen method as well as our backfilling?
We have a minimum coverage of
average is 400. 400,
yes. Our average is 400 fold, but our minimum is 20-fold. Those regions, there are few regions that have more genomic complexity. Those regions that do not have that minimum 20-fold do get Sanger backfill in order to ensure that we're covering all the important regions of the gene.
Is maternal cell contamination testing included in the test price?
Yes, it is. Obviously, these are, especially in the case of miscarriage and stillbirth, depending on the tissue source, there is a significant risk of maternal cell contamination. So as with any prenatal test that's done here at Prevention Genetics, we include maternal cell contamination as part of our quality assurance for these tests.
There's a few questions coming in related to indications for the testing and whether or not a single early miscarriage would be appropriate to be considered, or if there should be a threshold of multiple early losses.
It's more likely to be helpful for people who've had more than one loss, more than one early loss, because having one is so common. On the other hand, if a couple is particularly anxious, for example, if they're older or they have a concerning family history, it could be reasonable for selected cases to do it after just one loss. And certainly with second trimester losses and stillbirths, as well as neonatal deaths, it's appropriate to do it for any loss, including and especially the first one.
So here's a hard one. After CMA is completed and negative, do we have any data on the estimate that the next-gen panel, like what the clinical sensitivity is or what we would expect the yield to be?
Because this is a unique offering and that these 40 genes have never been studied in a significant group of this type of specimen, we can't at this time talk about the clinical sensitivity of the whole panel. However, Dr. McPherson can give us some more information about what she's seen with the Wisconsin Stillbirth Registry and some of the common disorders there.
Well, in the Stillbirth Registry, although most of the cases didn't have access to next-generation panels because they were collected over many years, including before those panels became available, if we look at the diagnoses that were made, we have about 10% that should be diagnosed with one of these conditions. Also, if we look at the paper from Mayo about the sudden death genes, which were not tested at all in the 3,000 that I've looked at, that suggests that there might be another up to 10% that we detect using those.
Is Prevention Genetics able or willing to help with evaluating records or photos or images on a specific case if the need arises?
This is Dr. McPherson, and I would be delighted to have the chance to evaluate images or other information on any specific case that is problematic. This is the kind of work I've been doing throughout my career, and I'm very happy to continue it in connection with this panel.
Can the panel be ordered on amniotic fluid samples from an ongoing pregnancy with a hygroma or hydrops, or only when there is an IUFD or miscarriage?
At this point, we are not validated for ongoing pregnancies. We have validated on cultured cells for no longer ongoing pregnancies, but we're still working on our validation of these tests for ongoing pregnancies.
Will parent of origin automatically be reported for structural variants or Mendelian disorders?
We won't be testing the parents automatically, but we may recommend parental testing because we will receive a sample on the mother if we're doing maternal cell contamination, but we won't necessarily receive a sample on the father. Part of our recommendations, if we do find something that is clinically relevant that could be carried by either of the parents, will certainly be to perform parental testing.
This one might be for Dr. McPherson. So POC microarray has a higher yield compared to carrier type. How do you recommend counseling patients on a microarray suggestive of trisomy 22, although less likely a translocation 22 is possible without a POC carrier type testing parents is needed to establish the recurrence risk?
Yeah, the reason that microarray is useful is because it will detect extra or missing genetic material. But if you do detect something that's not a common trisomy, then that will lead to recommended testing for the parents, which should not necessarily be microarray because the microarray would not be able to detect a balanced translocation in a parent.
What is the size cutoff for del dupes on array, and what is the pickup rate so far for clinically relevant and VUS copy number variants?
So this panel has just recently been launched, so we really can't comment on the VUS rate. Our cutoffs will be higher in these cases than in a pediatric microarray, for example, because we're looking for bigger rearrangements. So typically we'll be looking at 1 megabase duplications and 500 kilobase deletions or more. And part of that, too, is because these are by nature lower quality specimens, and so you may get a lot of noise in these cases. So we want to make sure that we're picking up the true positives.
If a VUS is detected on the next-gen panel, will you offer free family testing?
Yeah. Our policy at Prevention Genetics is for any variant of unknown significance detected by sequencing is to offer free family testing for up to 2 individuals in order to try to trace that VUS through the family and give us a little bit more information about the clinical relevance.
Can we send a specimen and ask that you extract and hold the DNA while fetal autopsy is pending?
Absolutely. And also, as I mentioned at the beginning, DNA banking is part of the service that we do provide here at Prevention Genetics, and so that is another option with these very precious samples that may be relevant for the family in the future. DNA banking is available.
Can you define a neonatal loss, and if there's an age cutoff where the panel maybe no longer is relevant, is it the first 30 days of life?
Well, the neonatal losses that I used in my statistics were defined as the first 30 days of life. However, I do think this panel is most appropriate for losses that occur in the first few days.
And there's one coming in about how we anticipate insurance to cover this test.
Insurance coverage for microarray for these indications has improved greatly recently, and insurance coverage can usually be obtained for next generation sequencing when an abnormality is suspected. We haven't had experience yet with the panel where there is not necessarily a specific abnormality suspected when we're ordering the next generation sequencing, but these babies have died, meaning that there is no question that they had a serious underlying abnormality, and that is usually helpful for obtaining insurance coverage.
And just one other thing to mention is that we can offer pre-authorization assistance here at Prevention Genetics, as well as fetal DNA banking if there isn't any coverage. Again, this can be important to the family at a later date.
There's a couple more still coming, so bear with me while I'm trying to read them. Related to a prior question, trisomies are commonly reported on POC microarray. Each time these are resulted, it seems that we need to order a parental carrier type each time to rule out translocation. A first-tier POC carrier type would have to establish recurrence risk.
When we're looking at first trimester losses, where these abnormalities are very, very common, it's not absolutely clear that we would need to do the parental studies. Another option, of course, would be if there was any tissue remaining from that same fetus to use a different method to try to confirm that it was a straightforward trisomy.
There's a question about if we offer test kits that are specific to POC or fetal tissue collection for this test.
So we've had some feedback from clients about this, and I am working directly with our client services group to create such kits. So we anticipate having those available soon.
I think that looks like we've tackled all of the questions, but if I've missed any, please feel free to email our shared genetic counseling group at clinicaldnatesting@preventiongenetics.com, and I think it's on the slide, on the screen, which is great. So thank you for your time, and we appreciate your interest.